My name's Liz Byrne. I'm the name nurse for Safeguarding Children for the Trust. So I manage the lead, if you like, the children's safeguarding team.
I'm Maggie, who you met earlier, Maggie Westbury. I'm the adult safeguarding lead.
So we're here to do your safeguarding children and adults training. I know you've just had Prevent, so hopefully you're all refreshed and ready to do something slightly different. So we call it Safeguarding Families because whether you're a children's worker or an adult worker, we have a duty to think family and actually safeguard whoever we come across. When we are dealing with adult patients, we have to think what's the impact of this on children they might have, if you've mental health issues, etc., drug and alcohol issues. And if you've got children, they've got parents usually, haven't they, or carers. So actually, what's the impact for the family? So we can't just go in with our tunnel vision and talk about, I'm here for children, I'm here for adults. We are here to safeguard everybody. We've got a responsibility. Are we mainly adult workers here today? Any children's workers? So we have a few. But you will, if you're working with adults, you will come across children quite regularly, I'm sure. So we're talking about safeguarding families, okay. So we want you to know what safeguarding is about, really. Safeguarding is something we do for everybody, and we would expect you to have a basic understanding of what constitutes abuse and actually recognise your individual responsibilities. As people working in the care sector in NHS, we have a duty to protect children and vulnerable adults, or adults at risk as the Care Act now defines them. So we can't just put our blinkers on and not see. Once you see something or you're told something, once you know it, you can never unknow it. So we cannot just not do something if we're worried. And that might just be seeking some advice from our teams, okay? An awareness of what information can be shared and with whom. With GDPR last year, everybody sort of got a little bit stressed about sharing information. The Children Act 1989, Section 1, first statement is, the welfare of the child is paramount. It's been amended a bit with the 2004 Act 2002 Adoption Act, but essentially the welfare of the child is paramount. And that will actually give you the right to share information if you have concerns a child is at risk of being harmed. That's our get out clause. It's not that we share everything we know about a family. We share, we've got 7 rules, haven't we, for information sharing. And actually it's about being proportionate and justifying why we're sharing. So GDPR is not a barrier to sharing information when you have got concerns about a child at risk, okay? And again, if you're worried, you seek advice from your manager or from our teams, and we will always advise you, give you some support with it. So I think people got a little bit anxious about GDPR, but for children's safeguarding, and I often say this, it's much more straightforward if you've got a child to safeguard, because actually we've got the Children Act, we can safeguard. Can I just ask, at what age does somebody become an adult and not a child? Are we all clear about that? 18? Everybody happy with that definition? Yeah, so while you might have a big 16 or 17-year-old in front of you, in law they are still children. They do, of course, have the right to make decisions about themselves between 16 and 18, but essentially, in law, they are children until they're 18. Okay, so when you get young adults on adult wards, please just be aware of that. And if there's safeguarding concerns, you need to be thinking, who do I need to talk to? Okay. So Maggie's also going to talk about mental capacity and deprivation of liberty safeguard, which is DOLS, which you guys are probably much more aware of than I am. And what to do when an individual, an adult, or an older young person may not be able to consent to care and treatment. So Maggie's going to talk about that later. Okay. So I would hope you've all got a basic understanding of safeguarding, but we're just going to talk about it quite basically today. What barriers may stop you from recognising or responding to safeguarding concerns? What might stop you?
Lack of information.
Lack of information, I don't know. I haven't got enough information to make that decision. Yeah, thank you. Anything else?
Not sure who to speak to.
Not sure who to speak to. Where can I get support with this? Who will know how to help me with this? Who's going to know something that will help? Yeah, thank you. Yeah. Anything else?
Person saying, I don't want you to tell anyone else.
Yeah. So a person saying, a child or a young person or a parent or whatever, say, I'm telling you this, but you mustn't tell anybody else. I don't want you to tell anybody else, I'm just going to tell you, and you must promise not to share it. Which is why we say you must never promise not to share things, particularly with a child, okay? If you've got a young person under 18 and they're going to tell you something that really makes you worry about them, then you cannot promise complete confidentiality, because actually to do so may place them at risk. Most times, if you can keep it confidential, you will, but if you come across a young person who tells you something you think, I'm really worried that these are at serious risk of significant harm, then you're going to have to take some advice on that. Okay? Because if a young person tells you that they are being involved with trafficking or child sexual abuse, you've got to help them, haven't you? And my sort of theory is that children tell you things, or young people tell you things for a reason. They picked you to tell them, to tell. They don't want you to then do nothing with it, I think, in reality. It's just how you do it. Okay? What else might stop you? What about when it's Friday evening, and I used to work as a health visitor for some years, and all the safeguarding seemed to sort of reach its peak on a Friday at 5 o'clock, and you're thinking, I'm just about to go home, and actually I've just been on a visit and I've now got to make a referral about a baby or a child I've just seen in the community. So if we've got other pressures, it's 5 o'clock, everything's shut, you're going to have to contact out of hours social care. You are going to be late off, it's going to be 7 o'clock maybe before you get home, and the kids need their tea and whatever. So actually sometimes we feel under pressure, we feel that we don't have time. And often these things happen when we have the least time. Okay? So that might stop us, we're too busy. What else might stop us?
Maybe you want to talk to the patient alone, but there's always someone.
Yeah. So you think something's wrong, but you really do need to talk to that patient or that client or whatever alone. And then you're going off shift and the moment's gone. Yeah. What about things like, oh, I've referred to social care before, they did nothing with it. I don't think it's worth it. There's no point. Okay. Some people think, well, the last time I made a referral about a child, nothing happened and they didn't do anything with it. Therefore, it isn't worth it. It's not worth doing. Okay. Or what if I have been working with a family for years and they really like me, I'm their favourite nurse, doctor, whatever. They really like me, they bring me chocolates at Christmas and whatever. But actually, I have a safeguarding concern for the child. That might stop us because we don't want to upset our relationship with parents, for instance. They're not going to work with us afterwards. That never should stop us. I have made quite a lot of children's referrals over my career, mainly as a health visitor actually, where I've sat in people's homes and said, I am concerned about the welfare of your child and I'm going to refer this to social care for support. And people like you telling them. If you rush off and do it without telling them, they don't like that. And usually they will work with you. Sometimes they have no choice, but I've not really, found that people, if you're honest with them and really support them, they will continue to work with you. I don't have time, all of those things. All of these things can stop us. And what might stop us recognising why we're here today? We're here to actually get a little bit of training. So if we're not really sure what to look for, how are we going to pick it up? Some signs with children, particularly pre-verbal children, under 3s, 2-year-olds, don't say a great deal, do they? It might be really, really hard to pick up there's a problem. You're not going to have a big disclosure from an 18-month-old, but what you are going to get, you're going to think the attachment there seems a bit, mother's not attentive when he falls over, he's not coming to mother, he's got a disordered attachment, all of those things. So it's about the non-verbals, isn't it, with children, or children with disabilities, or indeed adults with disabilities who can't communicate. What does that look like? And actually, does that mean anything? Is that behaviour telling me that there's something wrong here? And then we do a bit more digging. Okay. And what stops individuals from telling us there's a problem?
Fear.
Fear. What's going to happen? And I'll tell you what, probably the one that's most difficult is sexual abuse within families. The person most likely to sexually abuse a child is not some stranger off the street. It's a family member or somebody close to the family. So with sexual abuse, if a child discloses, there's that person that they're disclosing about, but it tends to drop a big bomb in the middle of people's families. And the family disintegrates. Because I think you'll agree that for most people, sexual abuse of a child is the most difficult thing to deal with. It's the most difficult category of abuse for most professionals. And if that's within a family or somebody, an uncle or whatever, then it has, ripple effect. You throw a stone into a pool and it has a massive ripple effect. And it can break families apart. So that can be very difficult. I'm not going to tell anybody because I know this is going to break my family up. And I know that people are going to be really angry with me. What else might stop people disclosing?
Lack of trust.
Lack of trust, yeah, which is why that's a really good one, which is why if somebody's telling you stuff, you should actually think, instead of panicking and running away saying I can't deal with this, you have to sit and listen, and then if you need to seek advice, you tell that person, thank you for telling me that, and I'm going to have to seek advice about it. If somebody has picked you to disclose, you should feel very honoured, pleased, whatever, not pleased, because you probably want to run the other direction, but they picked you for a reason. They think they can trust you, they think that you're going to do the right thing with it. So please just be aware of that. The other thing that people might not want to sort of might not want to tell you is, they might think that you're not going to believe them. We believe children on the whole. We do get the odd porcupine, but if a child's telling you something, listen and believe them until you've got other proof that it's not true. Children very rarely make up stuff about abuse. Okay, so we need to be believed. In that moment, you need to be there for that person. Okay, so a couple of scenarios here just to sort of run through. So a mother attends a clinic appointment and she's brought her 9-week-old baby with her. Whilst talking to mum, you notice a small mark on the baby's cheek. Are you worried? What are you going to do? Over to you.
Ooh, there's a mark there. How did that happen?
Yeah, very good. Ooh, I've just noticed.
It's always been there.
Yeah. So it's actually, I noticed that your baby's got a mark on the cheek. Looks like a bruise maybe. How did that happen? And you can ask those questions quite easily. What if we don't get a satisfactory answer? Which might be, I don't know. I noticed that this morning, don't know. Don't know how that happened. He hit himself in the face with a rattle. He rolled over and hit his face on his toy. Babies of 9 weeks don't roll over, by the way. So, we always have to be, particularly with infants under a year, and the younger the more, I think, we have to think about, does that sound feasible? And we do have, and it's on the Safeguarding intranet, and it's a policy, it's a guideline from the Safeguarding Children's Partnerships, and it's about an unexplained injury in a non-mobile baby. So if I was seeing this mom and she said, and I said, oh, that looks like a bruise, how did that happen? She might say, I don't know, I just noticed it this morning. So no explanation. Then I would have to follow the pathway about injuries in a non-mobile infant baby, okay? And that is referring that to children's social care, who will then have a discussion with the paediatrician and decide whether there needs to be a full child protection medical. If you're told that a 9-week-old baby's done that to themselves, you'd have to wonder why. People will come up with all sorts of scenarios. They hit themselves on the face with something. At 9 weeks old, very hard to hit yourself hard enough to bruise. Okay. What you sometimes find, not infrequently, with these babies that we see with just one tiny little mark on them, when they have their eyes checked, their heads checked, they have a skeletal survey, so a full body survey, that there are other injuries. You can have the tiniest mark on a baby, because babies don't bruise that easily. There's a little phrase called, those that don't cruise don't bruise. Okay? So if you've got a baby who's crawling at 9 months, which is 7, 8, 9 months, they might be crawling, and mum says, oh yeah, he was crawling, he stood, or he pulled to stand and he banged his head on the way down. He was fine afterwards and I took him to see the doctor. So we've got an explanation that fits. We've also got a good response from mum. She's actually sought advice about it. So you have to have both those things. So just please be aware of that guideline, because even if you're adult workers, you may come across somebody who presents with a baby or a young person, and you always ask that, oh, how did that happen? So just be aware that there is a guideline for those scenarios, and we have no explanation. Unfortunately, we do see babies who do come in with non-accidental injuries. It doesn't happen every day at Queen's, I'm not saying that, but we do get them. And babies die very quickly and get well very quickly when they're poorly. But babies, very, very fragile, aren't they? Under ones, they're our most vulnerable group, really. So how did it happen? Does it sound logical? And actually, when you're dealing with an older child or an adult who's got a disability, for instance, actually, we don't use disability as something to excuse marks, etc. If a splint's rubbing, then it shouldn't be rubbing. So you have to ask those questions when people can't tell you. Does that sound feasible? Could that person have hurt themselves, or is somebody else doing it? So always have that professional curiosity. Okay. Anything about that one? No? Second scenario, 26-year-old woman speaks very little English. And she comes to ED having fallen down the stairs. That's the story. She's 6 months pregnant and has a 4-year-old son. Husband comes with her. She can't speak English, or very little, but he can. What might be happening there with our professional curiosity heads on, our suspicious minds? Domestic abuse, violence, yeah. We're not saying that she didn't fall down the stairs, but we need to have that little bit of, oh, okay, did that really happen? What should we be trying to do with this lady? Sorry? An interpreter, very good, because we really shouldn't be using partners and family as interpreters, should we? Particularly if we think her husband may be a perpetrator of domestic abuse. We're not saying he is, just have your curious head on. What else should we try and do?
Speak to her alone.
Yes, speak to her alone. We should never ask the question about, is somebody hurting you? Do you feel safe with a potential perpetrator in the room? You should always try and get victims or survivors on their own. And I think Maggie's going to talk a bit more about that later. And yes, interpreters are really important. We will never ever be able to justify anything if we don't use an interpreter. We have interpreter lines, and I think they tend to use those a lot in the hospital, but we can sometimes get face-to-face interpreters. We have conferences and discharge planning meetings in the children's team, and we sometimes have to get an interpreter in because parents don't understand, and we need them to do that. And it's the same with any assessment that you do. You can't tell somebody this is what's going to happen in your operation if they don't understand a word you're saying. And it's the same with safeguarding. But you made a really good point. You need to ask them on their own, because who's going to actually say they're sat next to a perpetrator? So always just have that curiosity. How did this happen? We know that domestic abuse can ramp up when people are pregnant. We know that it can actually be the start of it, in fact, sometimes. So that's always something to think about. And we have children here with a 4-year-old and a baby who's going to be born in a few months who are witnesses to that, and that can be really emotionally damaging at the very least to children. Domestic abuse for children is really, really frightening, and it has an emotional impact. And occasionally they get caught in the crossfire and they get physically hurt too. So just to be aware that what's happening in that family may be impacting on the children, as well as this lady. And if she has fallen down the stairs, that's great. Well, not great. It's great if she's fallen down the stairs. But you know what I mean? It may be actually. But we as professionals have to have that inquiring mind, because she might just be waiting for you to ask. Okay, she might want you to ask. And nobody's asking. And therefore she can't tell you. And if you ask, it means that people understand you know it happened. It's nothing shocking for you. You've heard of it before. Gives people permission, but do it in the right way, in the safest way. Okay. Okay. Always follow your gut instinct. I don't know how people feel, but as a nurse for many years, you do develop that second sense, and doctors and care workers will tell you, you've been doing the job for a while and you think something's not quite right. And actually, if you sort of go with your gut, you can usually unpick why you feel that way. You can usually pin it down to something. I don't feel easy about this. I'm going to talk to somebody about this because actually something's not sitting right and I need to have a chat about that. I need to get a bit of supervision. That's when you need to talk to other people like your manager, like the safeguarding teams. Look at what's happened before. Has the story changed? ED at Queen's is a really interesting place when we have children who come in and with non-accidental injuries, because sometimes you find that the story that's told to the triage nurse, by the time it gets to the doctor, it's quite different. So your documentation is really, really important. Has that story remained the same? Has it changed? Do we think people are, telling us fibs? If the story doesn't fit, we have to ask the question. We have to have, again, professional curiosity, that bit of scepticism. Parents don't always tell us the truth. Shock horror, they don't. If they're trying to hide the fact that they've hurt their child, and remember this is a minority of people do this, but it's what we do every day, so we can talk about it, they're not going to tell you necessarily the truth. Okay? So sometimes we have to actually be a little bit cynical and a bit of digging, do a bit of digging. So you may need to admit a child, because we think there's a non-accidental injury, and child before adult. Even if the adults are telling you something, make sure the child's safety is not compromised. I think what that means is we should equally safeguard vulnerable adults and children. That's clear to me. But a child who's vulnerable, has nobody, with a parent, actually we need to safeguard the child if we think that the parent may be harming them. Document who's with the child, what's the relationship. And actually, if it's mum's partner, please do not write down stepfather unless they're married. It's mum's partner. Parental responsibility, mother will always have it, but sometimes we see in documentation, and I've seen it, it's a bit of a bugbear, that, mother will come in with a partner, and each time it might be a different partner, but each one's put down as stepfather. Unless you're married to somebody, you're not a step-parent. Does being a step-parent automatically grant you parental responsibility? No, thank you, it doesn't. You can gain it, it can be granted, but it does not give you responsibility. So if you're getting people to sign for operations or procedures, immunisations, it has to be somebody who has parental responsibility. And you're pretty safe if a mother's giving birth to a child. But if somebody's got a partner and people are starting to say that it's stepdad, then people might start to think, oh, they've got responsibility, they can sign for things, they can agree to things, and actually they can't. So you just have to be very aware of that. And I know most of you are adult workers, but it's something we need to be aware of. Because if something goes wrong and the wrong person signed, we'll be in trouble, apart from anything else. Who attends, clarify the relationship, who has got parental responsibility, who lives where, who else is living in the home. As a health visitor, I was really keen when I used to go into houses and say, well, who's living here? Oh yeah, what's dad's name, and what's your partner's name, and date of birth, and you sort of very kindly get all of this stuff, and it's really useful stuff sometimes. Sometimes when you've got concerns, you might actually find that you've got somebody living in a house who you're worried about. There was a big push on a few years back about unseen fathers or unseen partners being a risk, and that can sometimes happen. So we need to be asking those sort of quite probing questions. You can ask all sorts if you do it properly. I might not tell you, but as I think you said, oh, how did that happen? We don't have to say, we don't have to be pointing the finger. It's how we ask, and we're all good at talking to people, I hope, doing the job we do. Okay. So there are 4 categories of abuse for children: physical abuse, sexual, emotional, and neglect. Okay. So, physical abuse can be quite straightforward to sort of see. The baby we talked about, there's a bruise there, we've got no explanation. Goes on to have tests, it's got an old fractured femur or humerus or whatever. Physical abuse can be one of the easier ones. Neglect can be a bit trickier because it tends to be something that's gone on for some time. It's never just a one-off act. We talk about neglect, we talk about people like David Peter Conley, who was neglected. He was also physically hurt, wasn't he? It's something that can go on for years. The child that turns up at school, a bit smelly, lunchbox, nothing in it much, stealing sandwiches from the other kids. Do you remember the little Daniel Pelker, little 4-year-old, was hungry? You know, he was going around pinching food off other people, wasn't he? He was only 4. And he died, I think, from a fractured spine in the end, didn't he? Gross neglect. It can go on for some time. And schools are really good places to pick that up. Children who turn up unkempt. And actually, if you're turning up unkempt and you're a bit smelly, kids don't want to play with you, do they? It has a massive impact. Neglect can have a huge impact on children's self-esteem. Can be really damaging. The NSPCC did some research about 15 years ago now that actually showed that, you know, this chronic neglect can be more damaging than physical abuse to a child's sort of psyche and to the way they feel about themselves. Sexual abuse we've touched on. That's, I think, is a very difficult category. We are picking up more, I think, now than we ever have. But if somebody discloses that to you, that can be very difficult. And as I say, it needs to be handled really carefully. And emotional neglect or emotional harm. Somebody's living with domestic violence every day. That can be emotionally damaging. We have other things that fit into that category. So when a child's on a child protection plan, under the category of emotional, it's often for domestic abuse. But it can be that a particular child in a house is scapegoated. Have you heard that term before? Mm-hmm. There might be one child in a family who's treated differently to other children. The other children are all well fed, the dogs and the cats are well fed, and this child is actually the scapegoat. Everything that's wrong in the whole family is to do with that child who isn't fed, who isn't presented cleanly, who doesn't, isn't favoured. That can happen. And that's immensely damaging to children, you can imagine. We've all been children, haven't we? Imagine how that would make you feel. And that would go on into adulthood. Anybody heard of this phrase, the trilogy of risk? So the trilogy of risk is a term, it's also called the toxic trio. So it's about 3 things in parents, with parents really, which might actually impact and make the child more at risk. When we were doing serious case reviews, when we've looked at serious case reviews, they're now called practice reviews because we've changed things last year. Usually the children that were significantly hurt or died, and abuse or neglect was the cause, which is the ones that had serious case reviews, used to do them like an analysis over every 3 years. And you would find that the 3 elements that form this trilogy of risk, which I'll show you in a minute, most children who died or were significantly harmed and needed serious case reviews had at least one of those, 2, and some of them had 3. And if you have all 3, you've got a child who's really at risk. So anybody think of a parental issue that might fit into the trilogy of risk? The 3 things that might really increase risk for children. Drug, substance abuse, yeah. Drug and alcohol abuse, substance misuse, thank you, that is one of them. Domestic violence and abuse, thank you. One more. Mental health, thank you. Yeah, so that's a little triangle, 3 points. Mental health concerns. So if you are working with people with mental health issues, please do think, how does that impact on their child? We have a duty to share if we think it's impacting negatively. And it might be that you just want to share it with the health visitor, and then you'll talk to the parent and say, I'm really worried that you need a bit of extra support. Are you okay with me talking to your health visitor? And usually people are. If they're not, then you have to think about, how worried am I? Do I need to share without consent? But most time people are happy about that. But mental health can really impact negatively on children. Not everybody with mental health issues is a bad parent, that isn't what I'm saying. Most parents are really good, aren't they? This is a small minority. So please don't think I'm saying that because I'm not. Mental health issues are very widespread and lots of us have them. But yeah. Adult violence and domestic abuse. As we've said already, witnessing that is really damaging for children. And there is some research to show that children who live with domestic abuse, walking around on eggshells trying to keep the perpetrator happy, they almost get like a PTSD. It's almost like living in a war zone. It can affect them so badly. So domestic abuse is always an issue for children. And you will hear people say, oh, they don't know it happens, they're in bed when it happens. Children usually know. They know when parents are tiptoeing around, trying to keep the perpetrator happy. And as we know, it can happen both ways, more often male to female, but it can happen the other way. And adult substance abuse, that's alcohol, drugs. Because, you know, your allegiance, if you're really addicted to something, will be to that, won't it? Children may suffer because of neglect, there's not enough money to put food on the table, it's all going on drugs. Chaotic lifestyles, go to bed when we like, get up when we like. Parties, different people around the house, you don't know who you're letting into your house, children are around, all of that. Bit of passive smoking, bit of passive cannabis, all of that. So it's the impact on the whole surroundings really. So if you've got these things, please do think, how is that impacting? Does my client have children? Have I got a record of who they've got? Do you have children? Oh yeah, just take that down. You know, we should be being a bit inquisitive. And it's okay, but we need to be open and honest with people most times. Most times we'll tell people when we're concerned. Okay? Open and honest and people will work with us usually. Okay. So, risk factors which increase vulnerability. Infants under a year, we talked about the injury or mark in non-mobile babies. Babies of this age are massively vulnerable. You can see why, it's not rocket science, is it? They're tiny, they've got very little reserves. Okay, and it's really hard for people to understand that children can be hurt at this age, but they are. Minimum, you know, we don't see, not every day as I say, but babies are hurt and die. About 52 children a year die at the hands of a parent or carer. Not due to sickness, due to a parent or carer. Okay, that was the statistic, the last one I had. Premature babies and children with complex needs. Premature babies is pretty obvious, that they're even more fragile. But there's a lot of stress to having a prem baby, isn't there? There's a lot of anxiety, a lot of lack of sleep, worry. Babies can be quite difficult, they can cry a lot, they can have all sorts of illnesses like reflux that causes them to be very upset and to be difficult babies. So that increases stress in families. If you've got lots of children and then you've got this on top of that, that increases stress for people, doesn't it? You can understand that. You can understand anybody as a parent thinking, you know, I need to get away from here. You know, I need to get out of here for 5 minutes. Baby's driving me mad. Children with complex needs, so children with disabilities. A child with a disability is 2 to 3 times more likely to be abused as a child. Again, they're often, or they can be non-verbal, they can't escape, they have a lot of personal care, and different people caring for them sometimes, depending on the illness, or the disability, sorry. So they are more prone to, they are more susceptible. It can be hidden. So when we see something in a disabled child, whether we think, they're not telling us, but they don't look comfortable with that person, something's not right, they look uncomfortable, we need to be really inquisitive. What is that showing us? What is that person trying to tell us? What's that child trying to tell us? Previous history of abuse or neglect. So we always think about what's gone before, because sometimes it can help us inform what's coming. It's not to say that people can't pick themselves up by their bootstraps and improve things radically for children. It can happen. But, you know, the midwives will tell you sometimes they have mums coming in, you know, we do have safeguarding midwives that coming in, and it might be the 3rd baby that they've had removed because actually they just can't do it for whatever reason, and that's really sad. Poor housing, low income, chaotic families. So families where there's no sort of routine, children just, you know, are tired all the time, therefore they don't eat properly, therefore the behaviour is not good because they're tired, and that ramps up the stress, doesn't it? Children like routine. They don't particularly, you know, they might like going to bed at 1 o'clock in the morning and sleep until lunchtime like maybe mum does, if she's, you know, had a bit of a bender. But actually it's really bad for them. They like to know where they are. They want to feel safe and secure. Parents with a learning disability. So parents with a learning disability may need a bit more support, or a lot more support. So that needs to be put in, doesn't it? People need to be supported to look after their children, but it does obviously sometimes need looking at in a different way. Mental health problems, which is what we've said. Looked after children. So a looked after child is a child who is in the care of the local authority, being removed from parents. We'll talk a bit about those in a minute. And child sexual exploitation. Do you all know what that is? You've heard about it in Rotherham. Who saw 3 girls? Did anybody see 3 girls? Yeah? So I think it's still on BBC iPlayer, possibly. That was about Rotherham. So it's where a group of males usually will exploit for sex a group of girls and occasionally boys as well. And they will make them believe that they are in a relationship. So a young man might make, or a man might make a young girl think that they're in a relationship by gifts, by alcohol, presents, drugs, etc. And then when they've sort of hooked them in, we'll start then passing them round to their friends, for money usually. So child sexual exploitation, we do have a child sexual exploitation toolkit on the intranet. If you've got a young person and you think that there might be a risk, just be aware of that. So it's not gone away, it's still happening, just that we're more aware of it now. But if you do want to see 3 girls, I think it's on BBC iPlayer, hopefully still. It's about Rotherham, it's about what happened in Rotherham. Baroness J did a report on it. Have a look at that, it explains it really well. And looked after children can be more at risk for that, which we'll explain in a minute. Special guardianship orders. So a special guardianship order is an order which grants parental responsibility to somebody other than the mom or the dad, whatever. And it's often, it's a parent, a family member. The reason that's sort of there is that there was a serious case review done a few years ago now, I think it's in 2015, a little 7-year-old who died at the hands of her aunt who had special guardianship for her and grandma. And it's just, that was one of the outcomes from the serious case review which we talked about, was that actually, what support do these people have? We sort of, they need support. It doesn't, because actually, if a child's been removed from an abusive family and goes to another family member, what impact does that have? And actually, what was the upbringing of the person who's now got the special guardianship? Do they need more support? So that is something just to be aware of. Online abuse, I think you're all probably aware of that one. Really frightening, really worrying. Children used to be able to leave your bullies behind at school. People don't tend to do that anymore, do they? So that's a massive issue, isn't it? I'm sure I don't need to tell most of you that. Cultural beliefs. Cultural beliefs are never an excuse for child abuse, okay? So, female genital mutilation, you all know what that is, yeah? Culturally, that's practiced a lot in, I think it's West Africa mainly, but all over the world. It is illegal. It's illegal in this country, it's illegal in their countries as well. So actually, we never excuse child abuse because we say it's down to culture. I hit my child with a baseball bat because in my culture that's acceptable. It is not acceptable. We have the laws, and we also have our cultural acceptance of what we think is okay. So we can never excuse abuse saying it's somebody's culture. Gender dysphoria. Children or young people who have this gender dysphoria can be more, prone to things like self-harm, mental health issues. So they're more vulnerable. Makes them more vulnerable to target by people who are trying to target them. So, responding to your concern. So you're worried, you've got a worry or concern about a child. Listen, what are they telling you? What's the parent telling you? And how does that all sound? And what does the relationship look like? What are you seeing? You're seeing this bruise on the baby's face, maybe? Or you're seeing that this child looks frightened of the parent, it's cowering. I've seen that before as a health visitor. Parent just moves quickly. Child's, what's going on there? Why is the child doing that? Seek an explanation. Like with the bruise scenario, oh, how did that happen? Dig around a bit. Record, document. Very important. It's really hard to make referrals or to raise concerns if we don't have a record of what's been said or what's been seen. So documentation is really, really crucial. So please, just, I know you know that, but in safeguarding it's really crucial. Share. So speak to your team manager, speak to our teams, or if it's an allocated social worker, speak to the social worker. So our teams work Monday to Friday. We don't work out of hours, but please do get in contact with us should you need to. protect, share the information and refer and tell parents most times. There are some scenarios where you would not tell parents you were referring to children's social care. Anybody know what those are? Sexual abuse? Unless a parent knows, sometimes they know. So sexual abuse, if we think that the parents know about it or it's interfamilial. So most times we wouldn't tell parents. If we thought that the child would be put at greater risk, we wouldn't tell parents we were referring to children's social care. So if a child turns up at school with a black eye and says, "Dad did that to me this morning," being punched in the eye, we would not be ringing Dad to tell him we're referring and sending that child home, would we? That would put the child at risk. And if it put yourself at risk, you might not want to tell people face to face. You can do it on the phone. I've done it myself on the phone. So you wouldn't put yourself at risk to share that. So anything that would put the child at greater risk. So if a young person tells you, "I think my parents are taking me out of the country tomorrow to force me into a marriage," not arranged marriage, a forced marriage, very different things, you would not be ringing the parent up and telling them. You would be safeguarding that young person. And you'd be ringing the police who would safeguard. The police are the only people that can actually safeguard, remove children without any sort of court order. They would do it under police protection. That's why a social worker can never just walk into a house without an order and remove children. They have a policeman with them, or a policewoman. Police officer, I should call them. They're the only people who can remove children to a place of safety without a court order. Okay. So most times you will tell parents you are going to make a referral to children's social care, because the Children Act tells us we should keep children with families as much as possible. That's usually the best place for them. And actually, we need to work with families. And if we just go behind families' backs and don't tell them, they're not very happy. They won't want to work with us. Okay. So we're just going to do a little bit about looked after children. So a looked after child is looked after by the local authority. The very nature of being a looked after child means that you have been removed from your parents for some sort of neglect, usually, or abuse or whatever. So these children are already children at a disadvantage. So they are just more vulnerable to lots of things that other children can be vulnerable to, but they have a lot of vulnerabilities because they've been removed. So they're looked after by the local authorities, that's children's social care. They will have a social worker, and they'll have some sort of carer. They'll either be in a residential setting with lots of different people, or they'll have a foster carer. Okay. So there's different ways that children can be brought into care. A voluntary agreement order, which is section 20, does not give the local authority parental responsibility. It remains solely with the parents. So we might use that. They might use that, for instance, if a baby came into the hospital, had an injury, we're not sure how that's happened. Social worker might say to a parent at a meeting, actually, while we have the rest of the results, while we do our assessments, we would like your baby to be looked after by a person. Will you agree to that? And if they agree, they will sign a section 20 order. And usually the proviso of that is that actually they can remove that child at any time. So what will often happen in my experiences, they'll say, they sign a section 20 for, baby will go to stay somewhere else while investigations are ongoing. However, if that person tries to remove that baby, then they may have to go for a permanent court order, a care order. Okay, so that doesn't grant any PR to the local authority. Section 31 is a care order, which will give parental responsibility, will remain with the parents who had it before, but will also sit with social care. They will also have some parental responsibility. And usually, in these sort of cases, that will pick the parents because they will be removed and cared for elsewhere. Special guardianship orders we've already talked about. A placement order is something that is in place when a child is free for adoption. The only time a mother or a parent who has PR can lose that is by adoption or removal by a court. So once a child is adopted, the birth parent will lose their parental responsibility. But otherwise, even with all the children that we have in care, we have a lot of children in care, the parents will still have PR, will still be able to make some decisions for that child. But it will be regulated by the PR that the local authority has. So who has parental responsibility? I think we've covered that. Parents do. Mother will always have it. And dad, if his name's on the birth certificate, if they're not married. If they are married, then he will have it automatically. How would you know a child's looked after? And as we've said, it's important to know it because they will have increased vulnerabilities. We have a system that came into place about 18 months ago called CPIS, which is Child Protection Information Sharing System. So every child that comes in through Children's ED or Adult ED, a check is done on their summary care records to see if they have a child protection plan or they are looked after children. An alert will then go out to the social worker involved. Okay? So if you're working in those sort of areas, you will be used to checking the CPIS alert. And it's really important because it actually then, you realise they've got a social worker, they're on a plan, or they're looked after, and the very nature of being looked after most times increases vulnerability for children, and we can be aware of that. It is actually now being rolled out so that we're hoping soon that it will also show the children that are child in need on that alert. And it's important that you know because these young people, they're looked after, more prone to poor achievement at school, criminal acts. So I'm not saying all children are looked after. Exploitation of any sort, they're very vulnerable. Mental health issues, early pregnancy. All of these things because of the difficult start they have had in life, not necessarily because of the care they're receiving there. And you know, children are best placed with parents in most cases. And social workers, despite what you may think, do work really hard to keep children with parents. Because the alternatives are not always brilliant. So we talked about the Children's Act earlier. The key points, and I talked about that. Child welfare is paramount. Okay, that's the first thing you should be thinking about. We all have an accountability to recognise and respond in order to safeguard children. And that will be becoming law soon. That actually, as a health professional, if you don't notify or act on child protection concerns, you'll be in bother. I don't think it's quite in law yet, but it is coming. A duty on agencies and local authorities to work together. We've got a duty to share with our social work colleagues if we've got concerns. And their role is then to safeguard and to monitor and to assess. And we need to consider that if we get in there early with the help, it can be managed at a much lower level. So early help services within the umbrella of social care. It's always better and cheaper as well, actually, which is always consideration, isn't it? It's always better to get in early so that things don't escalate for children, things don't get really bad. So recognising that early support can be really, really helpful and desirable, really, rather than getting to that level where actually everything just falls apart. So we talked about a child in need, just to sort of run through what that is. You have a social worker if you are a child in need or a child in need of protection. So a child in need is Section 17 of the Children Act 1989, if you want to have a look at it. And it's a child who, without support, would not reach their full potential. That's roughly the definition. Okay. It's purely voluntary, though. So a parent who has a child who's on a child in need plan, has a social worker, can effectively say, I'm off, not interested, go away. And that's when it might need to ramp up if people are still worried. So Section 17, all disabled children really are child in need, but a lot of them don't have social workers. If every disabled child had a social worker, then I think we'd be running out. But there are some children that do need it. So Section 17, a child who needs support, yeah? Section 47 is a child who is suffering or is likely to be suffering significant harm, and that's the phrase, significant harm. Okay? They have social workers. This is the one that has the teeth. People cannot just disengage from this. There are plans parents have to adhere to. The next step will often be legal planning. Okay? If things don't work well. Most times it'll all be fine, but there are occasions where actually children need to be removed, need to have legal planning. Parents don't want to sort of work with social workers, etc. So Section 47 is your higher level, child in need of protection. Okay. So, just mentioning this, we did have a video which we're not doing this year. Just to be aware that if a child does not attend an appointment, it's very difficult for them to attend if they're little. A 17-year-old might say, I'm not going, or 15, 16-year-old, but actually, just think, please don't write did not attend, was not brought, if a child's young enough to be brought. It might be that a teenager is 17, so not coming, they didn't attend, they go to with their feet. But if you've got a child who needs to come for follow-up appointments, we cannot just keep allowing that to happen if it actually puts them at risk. If a child not being brought for appointments means that their health is suffering, then it may become a safeguarding issue. If you go on to, I think go on to YouTube actually, or go on to the local safeguarding partnership boards, put in was not brought, there's a nice little animation with this girl on there. It's really quite good. And that was done by Nottingham local authorities and health, so it's quite good. So please do go and have a look. So we don't use the word did not attend for children. Okay. Was not brought, because that means somebody's not brought them. It just puts a different slant on it. Did not attend sounds a bit benign, doesn't it? Oh, I just didn't come. But parents have not brought is a different thing. Again, depending on age. So when you refer for children's social care, you telephone it through first. There are the forms and the numbers, etc. on the children's page of the intranet, safeguarding intranet. Then you have to complete the referral form on the intranet and send it to our team, and we will send it on securely. We don't do online referrals because we like to see them, we like to quality assure them, we like to keep a record of them, and we will send them securely for you. Okay. But you have to pick the phone up to children's social care. It's different for adults most times, but with children we expect you to pick the phone up. So if you see it, please do something, because otherwise we can't stop it. Seek advice. We're around during the week. Please do. Send us an email, pick the phone up. The numbers are all on the intranet. Okay. Any questions? Bit of a whistle-stop tour, isn't it? Any questions?
Just simple question. If I suspected that there is a child abuse, okay, but my feeling was wrong, you mentioned that I have to admit the child. If I suspected that there is some kind of abuse or something, I might try to admit the child if I believe that there is any harm for the child.
I think it really depends on the circumstance. I think a referral, if you've got concerns of safeguarding, it should be referred. We're doing a lot of work about actually safe places for children. You know, a lot of the children that come in for the non-accidental injuries, the babies particularly, will be admitted, but not always. Sometimes they'll come in the next day, won't they, to a non-accidental injury clinic and have medicals, etc. So usually they're admitted because there's medical reasons, but sometimes children are admitted as a place of safety, which is not ideal, because actually, particularly with the COVID, we don't want lots of children in that don't need to be there. So it's about seeking advice, referring to social care, seeking advice from the named doctors or the safeguarding team. Yeah, can be tricky, but as long as we do the right thing with it, isn't it really? Social care, first and foremost, if we've got safeguarding, and we wouldn't be sending children home to an unsafe environment, would we? We would hope social care would support with that, but it's quite nuanced and it's can be quite tricky. Thanks. Yeah.
When a child is not brought to an appointment, does it always mean it's an abuse?
No. Just saying that if every child's not brought to an appointment, is it abusive? Of course it's not. You know, it could be that you've forgotten, that I've forgotten to bring my child, I slept in. I'm not worried anymore, I'm not going to bring him, but actually it's about then sending another appointment, doing that checking, making sure you've got the right address. And if we are worried that they've missed 2 appointments, we need to make sure that the referrer is aware. There is a policy, please look at the policy, it's called the non-attendance policy, children's policy. So we can't just assume, no, every child that doesn't turn up is not safeguarded. But actually, there are children who have real chronic conditions and parents don't bring them time after time, and that just poses a health risk, and that is a safeguarding concern. Thank you. Anything else?
It may just be that the family support would bring the child in.
Absolutely, yeah. Absolutely, yes. It's, so they might need support to bring a child, and we have to support them. We're not there to wag fingers, are we, and to chastise parents and make life difficult for them. It may just be that they need a bit of support. They might not even have money to get on the bus, you know. So we've got to have compassion here and support parents, which is why early help is really important. But yeah, it could just be as simple as that. So we need to do a bit more, rather than just sort of say, no, it doesn't matter. Have a think, does it matter? Look at the policy. There is a non-attendance policy. Please do follow that. Let the referrer know. If they've moved, do we have the new address? Are we sending the appointments out to the wrong address? It could be as simple as that. Thank you, yes. It could just be that they need some early help and support. Okay. Thank you very much. I'll go to Maggie.
Thank you. And just thinking about adults, when we think about was not brought, there are some adults who need to be brought to appointments as well. So there may be people in care homes, people with learning disabilities. The same applies. If they're not coming to appointments, we need to know why. And if they're repeatedly not brought to appointments, then that does become a safeguarding issue. And it has happened with a couple of care homes in the local authority in the last couple of years. And we have made safeguarding referrals because patients are missing out on medical care, changes to medication, changes to care plans because they're not being brought to appointments. So it works for adults and children. Okay, so I'm not going to go through the first 4 categories of abuse again, but there are 10 categories of abuse for adults. The additional 6 I will go through quickly, and the more you join in, it'll be a bit more interesting for everybody. So, financial or material abuse. So when we're talking about safeguarding adults at risk, so the definition under the Care Act is that an adult at risk is somebody who has care support needs and because of those care support needs is unable to protect themselves from harm or from the risk of abuse or harm. Okay, so if I come into hospital, I'm fit and well, and I've come in for a routine operation and I tell you that my partner has taken my bank card, they know the PIN number and they're taking money out of it and I've not given permission for that. Are you going to make a safeguarding referral for me? Right, you're nodding, a few. Okay. Have I got care support needs? No? Okay. So from a safeguarding perspective, under the Care Act, the local authority does not have to take that up as an action. However, what you might need to consider is whether that is domestic abuse, because it is my partner who is financially abusing me. Okay, but the conversation might be actually ask for your PIN card back. If you don't get it back, what would any of us do? Ring the bank, get it cancelled. What else? Yep, you can cancel it. Yeah, a lot of the time now, if you've got online banking, you can do that. Also, the consideration for, do I need to ring the police? Somebody's nicking something out of my bank account and I've not given them permission to do that. That's theft. So it's consider domestic abuse, ask those questions whether there's anything else going on, but it's not safeguarding at this point. When you've got an elderly patient who comes in, whose family member is their main carer, and they are taking money off them without their permission, then that's different. They're an adult at risk. They have vulnerabilities. They're not able to protect themselves because of those vulnerabilities, and that would go down the safeguarding route. Okay? So it's thinking about that all the time. Does this person have care support needs? If they don't, how else can I support them? So, discriminatory abuse. How do we discriminate against people? Why?
Gender, race,
Yeah, gender, race, religion, age, people with learning disabilities, people who are too fat, too thin. Multiple reasons why we discriminate against people. One of the things that we sometimes see, and which luckily has died off a little bit, but we have about 2 years ago, we saw an increased number of do not resuscitate forms, or the DNA CPR forms, where the reason for not resuscitation was identified as patient has a learning disability. The one that I saw said this patient has cerebral palsy, so resuscitation would be futile. Okay, I'm pretty convinced that that's not what the person who filled the form in meant. I'm pretty certain that that patient did have significant comorbidities that meant that resuscitation would be futile, but we need to be clear about that in our documentation. The reason for not resuscitating this patient is because they have significant cardiac and renal impairment. They would probably not survive long term if they were resuscitated. Talk about frailty, futility, and explain that reason, but do not use age or learning disability as a reason. Be clear about what we're doing. What about organisational abuse? How does that present? Can you think of any examples of organisational abuse that have been in the press over the last few years?
Working hours?
Pardon?
Working hours.
Working hours. being abused by our organisation. I can see where you're coming from, but when we're thinking about organisational abuse on this level, we're thinking about, has everybody heard of Winterbourne View? Mid-Staffs Hospital? Yes, so when we think about organisational abuse, it's quite often top-down. So when we look at the Francis report that was written about mid-staffs, there is an executive summary, but that's about 200 pages long in itself. It's a long read, but actually what it says is that from the top down, from the chief exec, from the trust board, there was a failure to recognise what was going on the shop floor. So they were trying to save money, they were trying to cut corners, and that had a massive impact all the way down through every single service offered at that organisation. And as a result of that, the care given to the people who needed it the most was failing. And because staff were exhausted, morale was low, there were lots of agency staff being used who were coming in and out of the organisation without the right training, without the right support. And at the end of that, there were approximately 29 people who died, and it was deemed that they died because of the neglect and abuse that had happened at the hands of all those people they'd come into contact at mid-staffs. So that was organisational abuse on a massive level. It can happen on a much smaller level. You know, on a ward, if you lose that manager and you lose that person who coordinates everything and has that vision and that insight and that overall control over what's happening day to day, it can happen very quickly. Mid-staffs have been deemed in the same way by the CQC as we had as good only a couple of years before this investigation took place, and it was found that all those people had died. So there had been close monitoring. There had been oversight of that, and that happened really quickly. Winterbourne View, and last year there was something on Panorama, and I've forgotten the name of the care home, but it was one of the Signet, Wharton Hall, that's it. But it was one of the Signet care homes, and both of those were where people with learning disabilities or learning difficulties were residents, and the carers in those homes were physically and psychologically abusing them on a regular basis to really, really significant levels, having massive impact on how those people were able to live their lives and on their psychological and mental health. So it can happen. That absolutely needs reporting. If you see anything like that in-house, if you see a change in how things are happening in a clinical area, then that needs escalating before it gets out of hand. But it's just, that's what organisational abuse is. And yes, we may get to the point where we're saying that because of the amount of hours we're expected to work. Hopefully not. Domestic abuse I'll talk about a little bit more. It gets a little slot all of its own because it's massive. Nationally, it's a huge issue. So we'll go into a little bit more detail about that. Self-neglect. Does anybody know what the definition of self-neglect is? No? There isn't one. So Nottinghamshire County Council have written guidance around self-neglect. It means something different to all of us. Could be that you're massively offended by the fact that somebody who lives alone doesn't shower every day and they only have a shower once a month or a bath once a month, and you might think that that is self-neglect. If that adult has capacity, then it's up to them, isn't it? If they don't wash very often. They might not have many friends, but it's their decision to make. And that's what we have to think about with self-neglect. Does the individual have the capacity to make the decisions that they're making, even if we think that they are not looking after themselves properly? And if they do have capacity, what is the level of harm? So we try not to make referrals without people's consent, and we very rarely make referrals about people with capacity who are self-neglecting. But if the level of harm or risk is high, then we will refer that into the local authority because they're the only agency. They've got they're the lead organisation for safeguarding. We can't enforce anything. We're not going to go out and knock on somebody's door and say, you must have carers. But the local authority can go out and they can try to support somebody in the community. So if somebody lacks capacity, it's simpler. If they are neglecting and they're coming to harm, then we can make those referrals and actually we can make decisions in their best interest. We can do that, but it's more challenging when you've got an adult with capacity who is making those, what we think are unwise decisions that are putting them at risk. And I would always advise giving us a ring about that because there's always a grey area. And modern slavery is, again, something that's quite big in Nottingham and Nottinghamshire. And you may well have seen things in the news. So going back a few years, we were looking at Sports Direct, and they were employing people from all over Europe that wanted to come here to work. So Sports Direct were never actually prosecuted around exploitation or modern slavery, but what was found when they looked at them was the fact that their employment techniques were dreadful. So they didn't care where people came from, they didn't care who had put them into giving them the advice to go and work there, they didn't look at their background, they didn't look at where the money was going. And people were coming to work, they were looking like they were emaciated, they had injuries, they were coming to work when they were really unwell because they had no choice. Because the gangs of people that were stopping them from leaving, those gangs that were taking all their money off them, were threatening them. If you don't go to work today, I don't care how sick you are, you need to earn that money and I want that money. If you don't, the people back home, your girlfriend in Poland or Romania or wherever that person's come from, we know where they are, we'll harm them. So the levels of threat were massive, and Sports Direct really did not care about any of that, and they didn't have any sort of safeguarding for those people that were working for them. So modern slavery is changing. So when we first came into talking about modern slavery, it was about trafficking, it was about sexual exploitation, but the face of modern slavery is looking a bit different. And when we think about Nottingham City and the people we might see, we are looking at people who have capacity, who are probably UK nationals, but are being exploited in their own homes. So we had a serious case review last year, and it was about an adult who was only in his mid-40s, who somebody had taken over his home. They were injuring him on a regular basis, they were taking money off him, they'd pushed him out to live in the shed, and they were just treating him, I'll say like an animal, but actually they were just treating him really badly, physically harming him, and that had been going on for about 10 years. His home was cuckooed. So that's a new terminology that will be coming out. So a lot of the time when we talk about cuckooing, it's about drug dealers who will take over somebody's home. They will come in, they will chuck you out, they will use you for selling their drugs or being a front for that home, but they'll take over your property and they'll threaten you, they'll physically abuse you, they'll threaten your family if you don't do what they want. So the modern slavery, the face of that is changing. So we want people to have consideration for, what are you seeing? If this person comes to ED and this is the third time they've come and they've got an injury and this is a 6-month period, and actually they haven't got any reason to be clumsy, they're not giving a really feasible explanation, what am I going to do with that? And in Nottingham City we have something called the MSVP, so the Modern Slavery Victim Protection. And we can refer into that if we've got any concerns, and they will look into it and look into the background. They'll speak to community policing teams. They'll look at what they know from a public protection background, and they will run with that, because that adult will very rarely meet the threshold for adult safeguarding because they don't have care support needs. So it's just thinking a bit more widely about what people are presenting with. Okay. So the Care Act came into force in 2014, and it basically puts adults in line from a legislation and statutory perspective, the same as children. We now have a statutory responsibility to protect those people who have vulnerabilities who are coming through our organisation. One of the biggest points that the Care Act makes is that we need to make safeguarding personal. So do not make decisions about me without talking to me. If you're going to make a safeguarding referral about me, you need to at least ask me the questions. So quite often in the clinical areas, you'll get family members saying, oh, my sister, she's the main carer for my mum, but she's not doing this, or she's taking money off her. When you ring us, the first question we'll say is, well, what does mum say? And quite often the response we get is, well, we haven't asked her. Why not? You need to talk to that individual to find out what she says or he says is going on in that environment, and not just take what other people are telling you. Okay. Always remembering, as we said about the self-neglect as well, it's about risk. People will be coerced and controlled and will be fearful. It stops them telling us information, and it stops them letting us know what is really going on in their lives. And we have to consider that. When we've got a concern and they're not forthcoming with information, we should always consider those factors and then still think about whether we should share information with or without consent. Okay, so if someone's in immediate danger, the best number to ring is the police. The safeguarding team are not going to be able to get there quick enough. Talk to your patients, find out what is going on. Raise your concerns if it's appropriate. The only thing different to children's safeguarding in that respect is that we don't talk to perpetrators. So we would never tell another adult that we were raising a concern about them. If it was a carer who was looking after somebody with a learning disability, we would not tell them that we had that concern because it increases the risk for that person. Can do a background check, but they're skimped. That actually refers to children safeguarding, really. So that's the Safeguarding Children Information Management team. And you can ring social care and say, I've got an underlying concern. I don't know if it's enough to make a referral. Is there anything you know that is going to guide me or that give me some advice about where I go with this? Use your systems to check for relevant health information. When we're talking about modern slavery, quite often what you'll find is that people are living in homes that are overcrowded, and it might be that there's other stuff going on there. And one of the gentlemen we went to see in ED, he'd come in with an injury. He didn't speak English, he had none of his legal documentation, and his story had changed 3 times as he'd gone through ED. So the man that was with him was talking for him. He'd changed who he was, so he'd been a co-worker, then he was an uncle, then he was his landlord. By the time we got through to Fracture Clinic, we had a whole different version of events from the one that had started in the front of house. And when we looked on Medway, when we put the postcode in and the house number, you could see that there were about 15 people living at that address. It was a 2-bedroom terraced house in St Anne's. So at the very least, that landlord is making a lot of money off a lot of people who are living in not very nice conditions. May well have been something else going on. We made the referral because actually that landlord is just basically making money out of people's misery. And they will probably all be paying about £100, £200 a week for that joy. Okay, so it's just thinking about how we use health information. Write down what the patient says to us. Use their terminology. Don't change it just because you want to be polite. If they swear, if they're sexually explicit, write that down. Okay. And share what is relevant. And if you don't know what's relevant, speak to one of our teams and we will guide you with that. Okay. Any questions on that bit? Okay. So, domestic abuse. This is the government definition. This will probably be changing this year. The domestic abuse bill was going through Parliament at a rate of knots. I should imagine that's slowed down a little bit now, and we might be waiting for it for a while. This was 2013's definition. The bits in red are the bits that they changed then, and it was recognised that from domestic abuse perspective, the physical aspect, while horrific, the coercion, the control and the threat and the fear and the emotional and psychological abuse that victims suffer is actually probably bigger and harder to deal with. It's something that stays with them longer. It causes more problems with their mental health and is much more difficult for them to get out of. So in 2015, controlling, coercive and threatening behaviour became illegal. It's very difficult to prove, but there is legislation out there to say that if it's proven that this is happening, that person can be prosecuted. We've had over 400 prosecutions in the UK since that came into force 5 years ago now. And the maximum prison sentence you can get for that is 4 years. And I think there's been about 15 or 20 people that have got that maximum sentence. Okay. So the police are looking at it, they recognise it more and realising actually the massive impact that does have on people's lives. 16 or over, so you're a child until you're 18, but it's recognised that teenagers, adolescents are in serious, intimate relationships at a much earlier age now. Women's Aid would like that age to be brought down to 13, but I suppose from a legal perspective, when we say that the legal age to consent to sex is 16, the government are going with this at the moment. So it encompasses all those different kinds of abuse, including honour-based violence, FGM and forced marriages. Okay, so it's a big issue. Covers a multitude of things. We know that domestic abuse is underreported. It's a hidden crime. But even so, Nottinghamshire Police get 1 phone call every 30 seconds relating to domestic abuse. It is huge. Men reporting domestic abuse has gone up by 198% in the last year in Nottinghamshire. Now, whether that's just because it's being recorded better or whether there is more recognition of people in same-sex relationships and it's being documented, that's improved, I'm not sure. The police aren't sure why that's gone up, but it is a significant increase. 1 in 4 women and 1 in 6 men will suffer some form of domestic abuse in their lifetime to differing levels. And as Liz said earlier, 80% of all victims will be women who have sustained injuries or are being abused by men. Okay, so the numbers are still the same. That hasn't changed an awful lot in the last 15 to 20 years. 2 to 3 women are killed every week by partner, ex-partner. or family member. That again has not changed. So we think we know a lot more about domestic abuse. We think that we respond to it better, but that has not changed in the UK over the last 15 years. We're still at the moment in our team, in Nottinghamshire, I think there's been 15 domestic homicides in the last 18 months. We're involved with about 5 of those now. The rest of those are nearly at the end. But they are significant numbers. It is a big issue. 80% of the phone calls we get into our team have some element of domestic abuse attached to them. And in children's safeguarding, again, a significant number, a massive amount will have some element of that in them. Still 1 man killed every 17 days as well, so the numbers for men are still fairly high as well. That potentially will increase because we are recognising that men are also abused. And when we say in the trust, what we see is a different picture. So men will quite often, if they are victims, tend to come in with really significant injuries as a one-off, rather than us knowing a history of what's going on. So quite often the calls that we will get will be from C30, the major trauma unit, where they've been stabbed. Whereas with women, what we tend to see is a pattern that's ongoing where they've reported and then pulled back and then reported again. And we tend to see the wider picture a bit more when women disclose. Okay. There's an increasing risk in teenagers. One, because they're in relationships. Why else do you think there's another risk to teenagers in domestic abuse? You're all quite young, aren't you? Any of you in the room got a teenage child? So, if you were getting into a scrap with your other half, and this had been going on for a while, and suddenly your 13, 14-year-old who's got a bit more testosterone in them or realise that they've got a bit bigger and a bit stronger, what do? They challenge, they do. They try to protect that person that's at risk, and that puts them in an increased risk because then the perpetrator has got to control 2 people. So the level of threat goes up. Both of you, this is what's going to happen if you tell anybody. So there is an increased risk because teenagers tend to try and protect that adult that's at risk. And as I said earlier, all those children who are living in a house where there's domestic abuse are at the very least suffering emotional harm. I think it's about 3/4 of the children on the at-risk register in the country have been known to be living in a home where there is high-risk domestic abuse. So significant numbers. Okay. So, how do you respond to a disclosure or a concern of domestic abuse? Has everybody heard of the DASH form? It's okay to say if you haven't. No, a few people haven't. Okay. So on our intranet site, on the left-hand side, on the adult side, there is a drop-down for all the different categories of abuse, and the referral process or the considerations are in there. The DASH form is a risk assessment document. It looks a bit long and painful. There are 27 questions on it, but they're there for a reason. So they are taken from the last 20 years worth of domestic homicides. What are the common themes that have occurred during these domestic homicides? And those questions then go on to let us review what's happening in that home and also let us make a decision about what level of risk that person is at. It is your risk assessment document. If you get a disclosure, you must use it. It is trust policy that you fill in the DASH form. If you're not sure what to do with it, it can be really challenging if you've never done it before. Give us a ring. We will come out and try and support you if we can, or it will at very least give you advice over the phone. But it's important that you use this document to help guide you with your decision making. Okay. It does have a page 10, which tells you however many yes responses you get, what to do with that information. What information can be shared and with whom should it be shared. But ring us and we will guide you through it. We'll come and get the form and we will then share it on securely with the right people. If there is a child in the home, you do not need consent to share information about domestic abuse. If it is an adult without children, you can't share that information without their consent unless they are high risk. Okay, but the form does tell you all of that. But ring us and we will guide you through it. Okay. So this is not just about domestic abuse. This is about any form of abuse. If you get a disclosure, let people tell you their version of what's going on. Try not to interrupt. You will have to ask for some questions. You will have to find out more information, but try not to press too much. And from a children's safeguarding perspective, if somebody's telling you about sexual abuse, we're not the right people to respond to that, are we? We don't need to ask them all of those questions for them to only have to tell a police officer or a social worker that again. Okay, so don't delve, don't dig, and don't try and drag too much information off them. Get that initial bit of information and then share that with the right people. Don't talk to the alleged perpetrator. Don't make promises about confidentiality, and don't be judgmental. We are judgmental, aren't we? We make decisions about people as soon as we see them. As long as it doesn't affect how we respond, that's fine. You know, quite often I'm sure a lot of us go home at the end of the day and think, oh, God, that's so-and-so, I'm sure they were trying to play me or whatever. But as long as it doesn't stop you from responding appropriately, we acknowledge what people say, we believe what they've said, and we share that information with the right people, okay? Whatever our personal opinions are. Listen carefully, explain that you might need to share it, explain why it needs to be shared, explain it's about support and help. Particularly in domestic abuse, we need to make sure that that person that's telling us that information knows that the police are not going to go knocking on that perpetrator's door and arrest them. It is about support for that individual and keeping them and their families safe. It's not about being punitive, okay? So if they want to go down that route, then it's their choice, but make sure that they're aware that this is just a supportive measure for them to keep them safe. Okay. So what's relevant information? If somebody comes into ED and they've got a fractured jaw and they say their partner did it, it's relevant to share that because that is a significant injury and we need to be saying this is domestic abuse because, and this is a significant level of harm. If somebody comes into gynae outpatients and they're coming in for a hysteroscopy, but they tell us that their grandson is stealing money off them, we don't need to tell the local authority that they came in for a hysteroscopy. We just tell them that their grandson's stealing money off them and they're a vulnerable adult because their grandson's their carer. That's all we need to share. It's just about being sensible. Don't share too much. And going back to the prevent stuff this morning, we don't need to tell anybody why they're coming into hospital, but we need to explain what that person's vulnerability is. So we're not breaching any confidentiality, we're not sharing too much medical information. It's about why is this person vulnerable and why am I concerned? Yes, so we don't have to share all of that medical information. We have an information sharing agreement with the police and the local authority. Sometimes we need to share information more widely, so with framework, housing association, those kind of people, but we need to have consideration for that if we're going to share that information more widely. Don't need to get consent if we're protecting a child, if it's an adult at risk, or if it's in the wider public interest. And again, that's where prevent sits. When we're sharing information about prevent, it is to protect the wider public. Don't share what you don't need to, and if you're not sure, ask the question. That's why we've got children's and adults and midwifery safeguarding teams at the organisation to support you with that. We know it's not something that you do all the time. Any questions on the safeguarding bit? I know, it's a long day. Okay, we'll get on. Mental capacity. This is an interesting one. I'm going to ask you a few questions. We'll get through it that way. So before I start with that, can anybody consent for me? No. Okay, why not? Fabulous. What if I didn't have capacity? Can anybody consent for me? Okay, potentially, yeah. Right, we'll come back to that as we go through. So, when do we need to assess mental capacity? This is a slight trick question, so I'll ask it more clearly. What is Principle 1 of the Mental Capacity Act? Anybody know?
Does the person have an impairment?
Okay, you're a few steps ahead. So, there are 5 main principles of the Mental Capacity Act. Principle 1 is that we assume capacity. Yeah, so everybody that comes up in front of us, we assume that they've got capacity unless we have reason to think otherwise. Can we assess capacity at the point of admission for all care needs? No. So there are very rarely people that lack capacity for all decisions, unless you're in ED and you've had a head injury and you're unconscious, or unless you are on a ventilator or unconscious. But actually, we cannot because it is time and decision specific. How do we assess mental capacity? This comes back to you now. How do we do it? What's the test call that we use? You're a step ahead. Yeah, you can. 2-stage test. Fab. Yes, it's called the 2-stage test. So what's stage 1 then? There, yeah. Is there an impairment or disturbance in the functioning of the mind or brain? So that can be head injury, substance misuse, alcohol misuse. It can be a learning disability, stroke, malignancy, metastases. So it can be any of those things. It doesn't have to be something that is never going to recover. So when you're in ED and you've come in and you're intoxicated, there is an impairment of the mind or brain for a period of time. What is stage 2? Going back to that gentleman there. Fab, yes. So this patient who we think has got an impairment of the mind or brain, when I ask them about this procedure that I want to undertake, can they understand what I'm saying? Can they retain it just long enough to repeat it back to me and show me that they've weighed up the pros and cons, that they understand the risks, the consequences, and communicate it back? If they fail at any one of those, then they are deemed to lack capacity to make that decision. However, we have to evidence that we have enabled participation. So Principle 2 of the Mental Capacity Act is enable participation. If you get a referral in from stroke services and they say, we think this person can understand what we're saying to them, but they cannot communicate as a result of their stroke, we're going to say, well, what have you done? Have you used picture cards? Have you used any electronic devices? Have you made sure that they've got batteries in their hearing aid, which is one that we get quite a bit? Can they write it down? Is there a family or friend that might be able to help to communicate better? Have we done everything we can in our power, to make sure that person can be part of the decision-making process? So they can't, they lack capacity for that decision. Who makes the decision about what care they receive? Pardon? So next of kin has no legal role apart from disposal of a body after death. So from a... Sorry? Yeah, potentially if you've got power of attorney. We're thinking about...
Would it be the doctor or the highest senior member of staff?
So the clinician in charge of their care has the ultimate responsibility for that decision. It needs to be a multidisciplinary decision in most cases. Again, unless you're probably down in ED and you've got an ED consultant saying this person needs to go to a CT scan now. But actually in most circumstances it would be speak to family, speak to friends, speak to the multidisciplinary team if there's a social worker involved. But ultimately it is up to the clinician to make that best interest decision. Okay. If someone is making an unwise decision, do we have to assess capacity? Hazard a guess. Does it matter? No. Because if I'm making an unwise decision, that means that I've got capacity to do that. So you don't have to do a capacity assessment because there's no impairment of the mind or brain. But this is where documentation is vital all the time. But if somebody's coming to you and telling you that they're living in a really high risk environment, that they've come in and got a significant injury that a partner or ex-partner has caused, but they're going back into that environment, your documentation needs to be really clear. I've explained to this person that I think they're at significant risk. I'm sharing this information via the DASH risk assessment form because of the level of risk. This person is minimising. They're still going back into that environment. I've advised them that I think that puts them at significant risk of further harm. Be clear about your documentation. What have I done? What have I said? What is the outcome? And who have I shared information with? And if I haven't shared information, why haven't I? Be clear about all of those processes. So, if there's somebody who is in our trust and they lack capacity to make decisions about their care and treatment, and they've got no family, no friends, nobody to support them, we refer for an IMCA, Independent Mental Capacity Advocate. We also have something called an IMHA, so IMHA, Independent Mental Health Advocate. So if you have a patient who is sectioned under Section 2 or 3 of the Mental Health Act, we should be referring them for an IMHA if they don't have any family or friends to advocate for them. We refer for planned medical intervention, not emergencies, and for those bigger life-changing decisions. Okay, they won't get involved just for emergency decisions because a clinician should be making those. The referral form is on our website, but you can ring us and we will send you a copy of the form. It's quite straightforward. Okay, so somebody at the back mentioned lasting power of attorney earlier. There are two different kinds. Do you know what they are? Yeah. So health and wealth. So if I give financial power of attorney to my partner today, as soon as it's registered with the Office of the Public Guardian, they can start doing whatever they need to with my finances. Should always be in my best interests, but I don't have to lose capacity before they can start acting within my financial background, okay? With health, it's different. If I give somebody lasting power of attorney for health, I have to lose capacity before they can start acting on my behalf. Always should be in the person's best interests. If somebody tells you that they have got lasting power of attorney for somebody's health, you need to see that. So it does say the original on there. Actually, we're quite happy with a copy as long as it's got the official OPG stamp on it, which is usually at the bottom of the page. If you're not sure, give us a ring and we'll come and have a look at it. Once they bring that in, you scan it in, we can put a little note onto Notice and Medway to say that we've seen it and we don't have to keep asking them to bring it back in. Over the last year, I've made 3 referrals to the Office of the Public Guardian where people have got lasting power of attorney and they are most definitely not acting in the best interests of the person that they have power of attorney for. So we can still challenge a lasting power of attorney. We still have those same safeguarding concerns and considerations. It doesn't change anything from that perspective. Don't get blinkered into thinking that those people can have carte blanche and make any decisions they want. If you've still got a safeguarding concern, give us a ring and we can challenge that. Okay, so from a mental capacity point of view, is that person going to regain capacity? Can the decision wait? If it's an emergency decision about treatment, then it probably can't. But actually, if Doris came in with sepsis and she's needed some antibiotics and we're talking about whether she wants to go into a residential placement rather than going home or whether she wants a care package, we need to wait until she's had 48 hours, 72 hours of her antibiotics and then reassess capacity for that decision. Try and make sure that the person is always part of the process to whatever degree we can and let them be making decisions for themselves where they can. Take into account feelings and wishes. We don't know most of the people that we see. Families, friends will know an awful lot more about what that person's values were, what their opinions were about certain things, and we need to take that into account when we're making decisions for them. Always should be equal and non-discriminatory and take any other factors into account. Life-sustaining treatment is around people who have made an advanced decision to refuse treatment. It used to be sort of like a living will. If somebody shows you an advanced decision to refuse treatment, you need to get some advice, I would say. I've only ever seen 3, and all 3 of those were not valid legally. So we do have a trust legal team, and I would advise that if somebody brings you that, before you start acting on it, you would get some advice from the trust legal team just to make sure that it is valid and applicable. Okay, we do get perpetrators of abuse who will write advanced decisions to refuse treatment on behalf of their partner and try to prevent them from receiving the care and treatment that they need, and we have had that in the past. So I would always get it checked out just to make sure you're comfortable that it's accurate. Okay, so moving on to the last bit, thinking about deprivation of liberty safeguards. Do we use restrictions and restraints at this trust? Yeah, you're nodding? We absolutely do. Yeah. Swiping in and out of wards. Patients can't leave unless we let them leave. There are cameras up and down all of the corridors everywhere. We are constantly monitored. There are patients who are in cohort bays being monitored because there are high falls risk. There are patients who are on alarms, mats, so that when they stand up, because there are falls risk, the alarm will go off. We have people on one-to-one supervision. We use haloperidol. We use lorazepam as sedatives. We do restrict and restrain people all the time. We can do that if somebody lacks capacity for those decisions, and we have to have a formal assessment of capacity for that, and it's necessary to protect them from harm, and it is proportionate. Okay. If you have somebody that you are using restrictions and restraints on, and you've assessed them and they are deemed to lack capacity for those decisions, you should make consideration for a deprivation of liberty safeguard. This applies to all patients 16 or over. We are going through a period of change with DOLS, and again, by the 1st of October this year, we were meant to be moving over to a new system called Liberty Protection Safeguard. That was again being pushed through Parliament quite quickly this year, but I should imagine that that's on hold now and that won't happen this year, maybe, who knows, but it is a period of change. This will not change though, this stays the same. Patients 16 or over, they must lack capacity for that decision and they would not be free to leave. Okay, so DOLS is a safeguard. We stop people leaving the organisation because we don't think it's safe. The DOLS paperwork that we send off to the local authority is to make sure that we're sharing that information with somebody who can externally view our decision-making process, and they can come in and assess those patients and they can say, yeah, we agree with you, or no, actually, we think you've made a bad decision here, you're illegally depriving that person of their liberty. So it is a safeguard for the wider public to make sure that we're acting appropriately. So this is the acid test. This came into law in 2014. And this is not changing even when we go over to liberty protection safeguards. If your patient lacks capacity for that decision at that time, they're under continuous supervision and control and not free to leave, then they should have a DOLS in place. We do understand that that would mean there's probably about 700 or 800 DOLS in place across this organisation at any one time, and it is about 7 or 8 page document to fill in. So we are taking a measured approach at the moment. So for those people that have mitts on, physical or chemical restraint or one-to-one supervision, they are definitely patients that would need a deprivation of liberty safeguard. If you have people who are sort of less heavily controlled, give us a call and we will advise you as to whether they need one as well. But it's consideration if they fit that acid test. Okay. So we just have to prove that this is what we've done. They lack capacity for this decision. We're doing this to protect this individual and they need to be here at this trust. It's got to be the least restrictive option. So if there is anything else out there that is less restrictive, that should be your first choice. You don't need to worry about the paperwork side of things because you just send it in to us. We help you fill it in and then we send it on to the local authority. But it's just to say on a Friday night, if nobody's in from the safeguarding team at 9 o'clock and your patient suddenly becomes really aggressive and agitated and you don't really know why and you're having to physically or chemically restrain them, then you can put a DOLS in on Friday night, and as long as we get it for Monday morning, that's fine. You can put that in and we will send it on to the local authority as long as they receive it in that 7-day time frame. So, in conclusion to all of that, ask questions, have some professional curiosity, don't just ignore things when it's right in front of your face. Make safeguarding personal. You would not like other people to make decisions about your life without you being involved in it, so please do the same for our patients. Think about risk, think about control and coercion and fear, and always remember that no matter what anybody is saying to you, if it's a criminal act, you have to do something with that information anyway, no matter what your patient is asking you to do. Speak to your safeguarding teams. There are 3 of us. Everything's on the intranet site, and we're happy to take calls whenever you need them. Any questions? Thank you.